In this video, we'll be discussing the medications used in the Neonatal Resuscitation Program, or NRP 8th edition. So let's jump straight in. Here we go. Always keep in mind that most newborns make the transition to extrauterine life without any interventions. Newborn resuscitation is usually needed because of respiratory failure. The most important and effective step in neonatal resuscitation is to ventilate the baby's lungs. Only about 1 to 3 in 1,000 births will require chest compressions and medications. Epinephrine is a cardiac and vascular stimulant that causes constriction of the blood vessels outside the heart, increasing blood flow into the coronary arteries, which can carry oxygen and help to restore cardiac function. It also helps to increase the rate and strength of cardiac contraction. See our video on epinephrine for more information. Epinephrine is indicated if the baby's heart rate remains less than 60 per minute after at least 30 seconds of effective positive pressure ventilation, or PPV, that inflates the lungs as evidenced by chest movement, and another 60 seconds of chest compressions coordinated with PPV using an FiO2 of 100%. Epinephrine is not indicated before you have established ventilations that effectively inflate the lungs, as evidenced by chest movement. The NRP guidelines recommend using a 1 milligram in 10 ml or 1 in 10,000 concentration of epinephrine. Be careful, as there are different concentrations available. The intravenous route is preferred, and the central venous circulation may be rapidly accessed using an umbilical venous catheter, or UVC. If the UVC is not available, an intraosseous needle can be used instead. If UVC or IO is unavailable, the ET route can be used. Emergency catheterization of the umbilical vein will not be an option in most out-of-hospital systems or initially in emergency departments, and an intraosseous insertion can be used. Attempts at inserting a peripheral intravenous catheter are likely to be unsuccessful. For the IV route, we should use a 1 ml syringe, clearly marked as epinephrine IV. And for the ET route, we can use a 3 to 5 ml syringe, also marked as epinephrine ET. Epinephrine ET and IV IO doses have been simplified in the 2020 guidelines for educational efficiency, making them easier to remember. Again, we'll be using the 1 milligram in 10 ml concentration. We can use the endotracheal route only while IV or IO access is being established. Our ET dose will be 1 ml per kilogram, but we can select any dose within the range of 0.5 to 1 ml per kilogram. Once the IV-IO route is available, we will give 0.2 ml per kilogram of epinephrine, but we can select any dose in the range of 0.1 ml to 0.3 ml per kilogram. Keep in mind that the uptake of epinephrine down the ET tube is not the most reliable, so immediately when the IV route is available, give epinephrine IV. Review the baby's heart rate 1 minute after epinephrine administration. Epinephrine can be repeated every 3 to 5 minutes if the heart rate remains below 60. We can also consider increasing the dose as long as we do not exceed the recommended maximum dose. Let's discuss volume expanders. Babies with hypovolemic shock maybe appear pale, have delayed capillary refill, and have weak pulses. In some cases, there will be signs of shock with no obvious evidence of blood loss. The administration of volume expanders is indicated if the baby is not responding to the steps of resuscitation and there are signs of shock or a history of acute blood loss. Volume expanders should not be given routinely during resuscitation without shock or a history of acute blood loss. Giving large volume load to an already injured heart may worsen cardiac output and further compromise the newborn. What volume expanders can we use? Normal saline is the recommended crystalloid solution for treating hypovolemia. Ringer's lactate is an acceptable alternative. It contains sodium, potassium, calcium, and lactate. Because it contains calcium, it cannot be infused in the same intravenous line as packed red blood cells. Packed red blood cells should be considered for volume replacement when severe fetal anemia is expected. If fetal anemia was diagnosed before birth, the donor unit can be cross-matched to the mother to ensure compatibility with any maternal antibodies transferred to the baby. If cross-match blood is not immediately available, use emergency non-cross-match type O Rh negative packed red blood cells. The initial dose of all volume expanders is 10 mL per kilogram. If the baby does not improve after the first dose, you may need to give an additional 10 mL per kilogram. We hope you benefited from this video. Kindly like, subscribe, and smash that notification bell. We'll see you in the next video. Have a fantastic day.